Good afternoon. I am AJITH NAGAHAWATTE and today we will be talking about enteric fever. Enteric fever is a condition where the bacteria from the enteric origin cause a disease where it could be mild to moderate or sometimes severe. Before we get on to the lecture in proper, I thought it's best that we discuss the outcomes first. I expect the students to be able to list the causative organisms of enteric fever, describe the pathogenesis of enteric fever, and relate the clinical features of enteric fever to its pathogenesis, and then of course list the microbiological investigations in enteric fever and describe the relevant specimen collection and transport for the diagnosis and interpret the results of the relevant laboratory reports in order to arrive at a diagnosis, and subsequently list the appropriate antimicrobials to be used in the treatment. Finally, I would also touch on a bit of prevention and the vaccines available. So those are the outcomes that I expect you to be able to do at the end of the lecture. Now, enteric fever is caused by gram-negative bacteria of the genus Salmonella. Salmonella, there are many serovars, of course, only one species, and that is Salmonella enterica. There are more than 2,000 antigenic serotypes, and all of them belong to Salmonella enterica and subspecies enterica serotype. Typhi and paratyphi ABC are the ones that cause enteric fever. Ideally speaking, Salmonella typhi or Salmonella enterica subspecies enterica serotype typhi causes typhoid fever, whereas the paratyphi A, B and C causes paratyphoid fever. Now, most of these Salmonella, other than the typhoid fever and paratyphoid fever causing Salmonella, are animal pathogens or they are harbored in animal gastrointestinal tract. While typhi and paratyphi are in humans. And they cause a bacteremia and subsequently a metastatic disease. Now, a little bit about the antigenic structure of Salmonella or the Enterobacteriaceae for all its worth. Salmonella are motile organisms and they have flagella. And there is the flagella antigen, which is strongly antigenic, and there is a rapid rise of antibodies when the antigen is present. The cell wall polysaccharide antigen is somatic antigen, is less immunogenic and also cross-reacts with some other Enterobacteriaceae. So therefore there is a problem in interpretation of these results, serological results. Then the capsular or VI surface antigen is present in Salmonella typhi and paratyphi C and is poorly immunogenic, and antibodies disappear very early and sometimes persist only in carriers. Now, the pathogenesis of enteric fever, the organisms are ingested either through food or water and they get into the gut, having gone through the hostile environment of the stomach, acid pH. So the dose of the organism and the pH of the gastric acidity are the ones that would decide whether it could establish infection or not. Having reached the small intestine, the ileum, they enter through the endothelium and get into the submucosal lymphatics and through the lymphatics to the intestinal lymph nodes, mesenteric lymph nodes. And then from there they enter the bloodstream and they spread to the blood. And initially in the mesenteric lymph nodes these organisms multiply. And the few organisms that enter the lymph nodes now have multiplied and they get onto the thoracic duct and cause bacteremia, get into the blood and causes the primary bacteremia. And from this primary bacteremia, the organisms further travel to sites like the gallbladder and also the reticuloendothelial system. And they multiply in those sites, and subsequently there is a secondary bacteremia which actually brings on the fever and the real illness itself. Now the organisms that go into the gallbladder are shed from the gallbladder to the intestine, and then they cause further multiplication in the intestine, particularly in the Peyer's patches or the mucosal lymphoid collections, and there is ulceration and sometimes necrosis and perforation of the intestine. So those are the complications. And then of course they also travel to the kidney and the gallbladder, and then they are eliminated or they get into the environment once again through the urine and the feces. So that is the pathogenesis. So the clinical symptoms would appear roughly in about 2 weeks, where the primary bacteremia is about 1 week to 10 days, and then maybe later than about another week after, there would be the secondary bacteremia and the real fever that comes on. So as I said before, the infective dose could be about 10 to the power 6 to 10 to the power 9 organisms, and of course in outbreak situations it could be about even 1,000 organisms. Disease itself could be mild phylexia or severe fatal disease. Fever, malaise, anorexia, frontal headache, abdominal discomfort, these may be the prodrome, constipation followed by diarrhea, and then relative bradycardia, that is where the rise of temperature doesn't correspond to the rise in the heart rate. So ideally with the rise of temperature there should be a higher heart rate, but it is relatively low, and that is why we call it relative bradycardia. Hepatomegaly and splenomegaly are important features that we should elicit, and rose spots are there in the skin, and in the white skin people it is more obviously seen, as we can show these tiny pink patches where we can actually isolate the organism from that sites as well. So complications include intestinal perforation, intestinal hemorrhage, myocarditis, cholecystitis, arthritis, abscesses, nephritis, and osteomyelitis. Relapses can occur after recovery from the initial infection, and in about 10% of patients this could occur. Severity is less in the relapsers than in the original illness. Carriers, more females are carriers than males, and convalescent carriage, that is carrying the organism in the intestine, occurs for about 3 months following the infection, and that is called convalescent carriage. Permanent carriage could occur in about 5% of patients, and that is of course declared by more than 1 year of carriage in the intestine. So if we are to rule out that there is permanent carriage, that means we need to do 6 stool cultures, consecutive negative, for us to rule out that there is fecal carriage which is permanent. What investigations should we do? I'm not talking about the general investigations like the hematological ones, the full blood count and all that. I confine myself to the microbiological investigations. So the best and the gold standard would be isolation of the bacterium in culture. In the first week of infection, that is the first week following fever, the organism could be isolated from blood. And blood cultures would be up to about 90% in the first week positive. Then of course, there was also in the past that we used to take the blood and allow it to clot, took the serum for serology and the clot for clot culture. But now that has gone out of vogue, but still the textbooks would refer to clot culture as well. Stool cultures are from second week onwards, that is on the second week of fever, stool cultures can be done, and then urine cultures ideally in the third week of fever. But blood cultures still could be done in the second week as well as third week, though the positivity would be less. Bone marrow cultures could still be positive in spite treatment for up to about 5 days. So that is the best if possible. And apart from isolation of the organisms, the next best would be to demonstrate antibodies in serum, which is the standard agglutination test or the Vidal test. Some microbiologists would not consider it so as an important tool in the investigation, but still, for historical reasons, as well as in situations where we are unable to perform all the other investigations, the Vidal test might come handy. Then of course, for research purposes, we can demonstrate the antigen in stools, in blood and urine. So blood cultures, as I have shown in this graph, would be positive in the first week of infection, and that is coming down with the time of fever. First week the best time, second week still good, but third week urine is superior and stools are superior. Vidal test of course is not the best to do in the first week of infection because that is where we demonstrate antibodies. So naturally antibodies would take time to develop and therefore they won't be positive in the first week itself. Maybe by the time the second week the antibodies would be positive. Now in the serological test there are antibodies, and these antibodies could be demonstrated either in the first sample where we do it in the initial week and then subsequent sample in the second week or 10 to 14 days after the first sample. We can demonstrate either the antibodies from negative, no antibodies, to antibodies positive. So that is a seroconversion. Or we can also do a fourfold rise of antibody titer. That means the concentration of antibodies will go up by fourfold, and then of course a high titer of antibodies at any stage might again give us a clue to the diagnosis. But whatever we do, we need to remember that rise of antibodies depends on a lot of other factors. Previous infection may have the antibodies present. Stage of the disease, as I said earlier, the disease, no antibodies. Symptoms of subclinical attacks may cause antibodies to rise. High titers in endemic situations, like in areas like Sri Lanka, India, and the Asian countries, the Southern the Americas, the South Americas, these are the places which are endemic for enteric fever. Then following immunization, people who have already been treated, then there is a condition called anamnestic reaction where antibodies goes up due to certain other conditions like fever, any other fever, pregnancy, connective tissue disorders, so those can happen. And O antigens, the somatic antigens, are capable of cross-reacting with other Enterobacteriaceae antibodies, and somatic antibodies won't last long, and flagella or H antibodies appears very slowly, but of course they last long. So these factors need to be considered when we interpret the Vidal test. So what are the antigens that we use in the interpretation of the Vidal test? We said initially that there are three types of antigens: the somatic antigen, the flagella antigen, and the capsula antigen. The somatic antigen is common to both Salmonella typhi and the paratyphi. So therefore we will look for antibodies against the somatic antigen, but we may not be able to say exactly whether it is Salmonella typhi or paratyphi. But with the H antigen, whether it is typhi H or paratyphi H, then we might be able to say differentiate from typhi and paratyphi. VI antibody will arise only in the case of typhi or paratyphi C. So those are the basic rules about antibody detection. Non-reaction, or if there is no reaction in the first week, or the test is negative, it doesn't mean that the patient is not having enteric fever, because, as I said before, the antibodies takes time to appear. And the fourfold rise, seroconversion or high titers of more than 120 are significant in the interpretation. Carriers can be detected by isolation of bacilli in stools or urine. Some test for VI antibodies in serum, and more than 30% of carriers do not have VI antibodies in serum. Convalescent carrier has to be tested until 6 consecutive negative stool cultures to declare end of carrier stage. Treatment. The antibiotic treatment, of course, initially it was chloramphenicol. Chloramphenicol, with the use of chloramphenicol, there was a reduction, a huge reduction in the mortality and morbidity. But resistance developed, and there is R factors or chromosomal or extrachromosomal elements, actually plasmids, which contain resistance to antibiotics in Salmonella, which are more than for one antibiotic, and those are multiple resistant strains, and those strains are R strains, or referred to as R strains, resistant strains. Ampicillin and cotrimoxazole was used subsequently, but again these resistant strains or R strains have evolved to be resistant to all chloramphenicol, ampicillin and cotrimoxazole. Ciprofloxacin is the drug of choice considered today, and of course, third and second generation cephalosporins also have been used with very good results. For people who are unable to be cleared by antibiotics, some may resort to surgery, and that is cholecystectomy together with antibiotics. Control, I would say, safe drinking water and proper disposal of sewage will be the most in favor of control of enteric fever. Killed at 55 degrees centigrade in 1 hour or 60 degrees in half an hour, boiling, chlorination, pasteurization of milk, all would kill the organism. So therefore, boiled-cooled water, chlorinated water, safe drinking water would be modes to eliminate enteric fever. Immunization is available and indicated to travelers who get into endemic areas as well as contacts of typhoid fever patients. So the wholesale inactivated vaccine, the TAB, is available, but it gives very short protection. The protection is very short-lived. The live oral attenuated T21A strain is available, and that gives a fair amount of immunity. Purified VI polysaccharide capsule vaccine is given intramuscularly, which also gives a fair amount of immunity. Thank you. If there are any questions, I would like you to ask me for any clarifications or questions during the presentation I made. Thank you.